self-pays like that as part of your regular AR, in my opinion.
Yeah.
Do you have Medicare a backlog at all for payment?
There's a little bit of a backlog. We still have some claims that we haven't been able to submit on some of our providers. But for the most part, most of our Medicare money is coming in pretty timely.
Good.
Medicaid is been fairly timely. We haven't seen any issues in the system with those recently. It's just a matter of really identifying those accounts and making sure that the insurance companies are, paying claims. And they have all kinds of reasons not to pay claims as well, so, any reason for delay is
Money in their pocket.
they're wanting to hold on to their money.
Right.
Just-
Yep.
Yeah.
Any reason not to pay it?
Yep.
So, I would
Okay.
hope that number would come down, but it's just not coming down as fast as I would like it either, so.
As far as accounts payable, I saw that there were some late fees we're having to pay. Are we in dire straits with any of our accounts payable?
There's days they call and say, if you don't send us the check today, we're not sending you supplies, so yeah.
Yeah.
Yeah, we've had that.
It happens.
Are we getting any
experience.
better? Are we seeing,
Right now, we're no better. I mean, with the money that's coming in by the end of the month and our cost report, yes.
and that's just in the next couple of weeks? Okay.
I mean, I did report last time, and it's true that the number, since I came, has gone down considerably. It was 1.2 million when I came. It was 558, 560, something like that. That's a huge decrease, but part of that was the next gen,
And there's
contract.
Still some of that in there too.
Yeah, there is a couple $100,000 in there of the 700. Right now, it's about, what, 730, 740?
Yeah, 770 today.
770, okay. So, it went back up, but again, it's a fluid situation. You keep adding and, today, was that after I signed a bunch of
Yeah.
checks? I signed it right before the board meeting. Stacy brought me a big bundle of checks, and stuff. But, it wasn't probably a huge dollar amount.
No, about 50.
A huge dollar amount is, it was probably, what, $30,000, $40,000?
It was 50 today.
50-some
So,
thousand.
I mean, it's a
dollars.
lot,
That's-
but
It's a
not-
lot, but
not in
it
full.
doesn't get your balance down when you keep, at the beginning of the month, all your vendors are, sending you bills again and stuff, so.
As part of the accounts receivable, is that included in that? Does the health center still owe money to the hospital?
No, well, they owe money, but.
Is that
Memo.
included in that?
No.
No. Well, how much is that? Do we know what that balance is now?
No, they're still going through the audit on that, but it's probably around 300, 350.
So that's way better than it was. It's a lot better
Yeah,
than it was.
but a lot of it was taken care of through.
The contracts.
the
Intercompany swaps,
intercompany,
whatever you call them.
Okay. Okay. Was there a recommendation for the finance?
Well, there's a little bit more there.
Sorry.
There's 371,000 coming in. That's from accounts.
Cost report settlement, right?
Yes, cost report settlement. And there also was 114 that they decided, I guess we decided in the finance committee, to go ahead and accept. And then we're gonna put that into the line of credit that
Can
we
you,
have.
could you say that one more time for me? I missed.
Okay, it's 371,000
Okay.
plus 114,000.
For what?
Well, the 114,000, if I could, is what they call a lump sum payment from Medicare. And basically what it does is it applies our new rates that they have assigned to us on our last 6 months of business with it. In other words, they go back and say, okay, you've had, 150 skilled days, and we increased your price by $300, so they take that 150 times 300, and that's part of it.
Okay.
The cost report settlement was for last fiscal year, you know, from.
So that's what the 371,000 is,
Right.
the cost report?
And so
Okay.
Cliff is talking about the first 6 months of this fiscal year.
Okay.
There's another adjustment, which was, thank goodness, positive, so there's a little bit more cash coming in that direction also.
Well, we like not to have to give them, because it means our business is doing better, right?
Correct.
But the important thing is 114, we're gonna set aside, but in the letter of credit. But-
We don't want to let Stacy get it so that she can
Keep
pay a
that
bunch
one
of
Stacy.
payables.
Well,
now.
the
So
catch
we-
is, the
So-
catch with it is that it is possible with those increased rates that next time around, when we do a cost report, Medicare may say you're on the other side of that and you have to
Right.
give something back.
Right.
So rather than spend that paying down accounts receivables and then be sitting there going, oh, we gotta give it back and we don't have it, we're gonna pay down on the line of credit with it. That'll cut down the interest expense we've got in the meantime, and then if the cost report comes in and we have to give something back, we can borrow it back out of the line of credit. We've cut the interest expense in the interim, and the money is there available to us. So that's what we're trying to accomplish with that.
To pay down the line of credit.
Yeah, we use it to pay down the
What-
line of credit rather than spend it on payables, with the understanding we may have to take it back out if Medicare comes back and says, well, once we did those no rates and estimated it, it resulted in you actually getting a little too much, so give back.
Yeah.
That's correct.
So we want to be in a position where we've got it someplace to
Yeah.
get it from.
Can't have it, Stacy, can't have it.
What's the line of credit balance at right now?
420. And we're setting ourselves up so that we will have to pay back, because we are
With the new-
decreasing our costs, and
With the layoffs and stuff.
hopefully
Right.
our revenues or our volumes will increase, so that with those two scenarios, that's what means you pay back Medicare, which means you're doing better. I don't know, if you have to pay
It's
money
kind of
back, that
odd.
means you're doing better.
Well, yeah, what happens is
Isn't that
if your
complicated?
cost per patient goes down if you have more patients.
Right, that's right.
You know, if you pay a nurse for 8 hours and she's got
Crazy.
3 patients instead of 2, your cost per patient goes down. So that's what
It's
that's about.
crazy.
But in the last couple, 3 years, we've been on the other side of the coin where our costs have gone up and our volumes went down, and that means you get more money back from Medicare that way. So now we're going into hopefully the opposite scenario.
We think we're going in the right direction, so we want to be careful it doesn't bite us.
Right.
Okay, and then we have a vet tax of 100,000, which is coming in February.
Where does
Right.
that come from? Who pays that? Is that from Medicare as well?
That's from Medicaid.
Medicaid. How much is it?
About
Well,
100,000.
yeah, that's just an estimate, though.
And when is that?
Hold us to that. That'll be by the end of February. Probably grows.
So that helps on the cash flow.
Yeah, it does. So there's a,
Well-
among the depressing news, there's a little bit of good news here.
Want to make sure I got that in.
Yeah.
You
So
got
is
it.
there a recommendation from the finance committee then?
To go ahead and accept this report,
Okay.
and looking forward to the new budget
Oh, yeah.
and the new numbers.
Yep. I'll second that.
Okay.
Also, we commented on getting the report 2 weeks before
Yes.
Yep.
that was very nice.
Yes, that was nice to get it ahead of time. Yes.
It was just.
Wasn't
Okay.
2 weeks, but it was.
So we had a second on accepting December's financials. All in favor?
Aye.
Aye.
Any opposed? Okay, we need to approve November's as well. I know we don't have them in front of us right this second. But did everyone add, maybe we wanna, did you have something to say, John?
I was just gonna say, I have looked at them, and I feel comfortable to, I certainly can't give any details, but I'll move to approve.
Okay.
I did look at them when they came
I would
through.
second that.
Yeah, okay. All in favor of approving our Novembers?
Aye.
Aye.
Any opposed? Okay, let's move on to, well, medical staff report, but I don't think we have any.
Laura's not around, no,
Laura's
she's
not
probably at
around.
the clinic.
Okay. We We don't have any privileging requests. Next Gen report. What is
Deb?
going on with Next Gen?
Kirsten too. I'll chime in too a little bit here.
Well, Next Gen, once again, as we looked at going live, we decided that there were things that just were not gonna support us in moving forward again. So we have, once again, delayed the go live date. We confirmed the go live date earlier today, which is March 3rd. There are things, on both sides. We were still working through some clinical stuff with a piece of it called Care, which is part of our discharge piece and our Medicaid reconciliation piece that are not really working as we think they should in the system. There are some issues with some pharmacy pieces. There are some issues with getting the bills and making sure that the clearinghouse is accepting of those claims. One of the things that we had, or that we identified late December, was that we were in need of switching clearinghouses because the clearinghouse that we currently use was gonna charge us $10,000 to rebuild the system and accept the claims from Next Gen versus accepting them from Tech Time. So we are converting to a company called Healthy Web, which is a Montana-based company, which is a affiliation subsidiary of Blue Cross Blue Shield. So they've been in the state for a long time. They're very good to work with, and they have a very good product as well. It's a little less expensive than ePremise is on a monthly basis, but it's
The previous company.
yeah, but the maintenance fee month per month is not a huge difference. It's a little bit cheaper, but that $10,000 to convert over is just one of those things that people are making money on, as the government says we all have to have an EHR. So we didn't really feel like we wanted to go down that road. So March 3rd, our employees for the most part have done well as far as working in the system. We're waiting for all of the system to be brought back up since they took it down and cleared some of it out, preparing for go to live. But the clinical piece is back up. The financial, they have a little bit more stuff to put back in the system, and then we can start testing again from the financial side. But
How confident are you that we're gonna hit that March and be successful?
well, I wanna say yes, we're gonna be there, and we're gonna,
And has
encourage
Next Gen
every-
been cooperative? Have they been doing the
Um,
pieces that they say that they?
I think everybody's been working hard from both sides. I just think that there's some things that are just, with any company that you go with, you're gonna end up with problems. St. Pat's and Community with Cerner and Epic, the biggest products in the nation, are struggling with some of the same sorts of things. Meaningful use is hitting us. We're gonna have to start reporting for 2014, and that's one of the things that we're really relying on Next Gen to have in place. It's not available yet. And so we're really hoping that that's gonna be a piece that comes, that we can get in place so that we can start testing claims and meaningful use for that 2014 deadline. So there's just some of that stuff that we just are hoping that it'll pull through and work for us, so.
What
Kirsten,
is,
for-
what is the deadline, 2014, specific? Do you know?
Let me walk through that.
Yeah,
maybe.
Larry can walk through
Okay.
that.
It has some contract implications too that I talked to the attorneys about. But, Kirsten, maybe we could hear from you on the clinical side if you have concerns or, add your 2 cents worth in here.
No, I don't have any concerns. I'm not always the most optimistic person, but I think that the hospital has done its job in accepting and participating in the training that's been offered to us, the orientation to the product, as we discover pieces of the product that we had not been trained on. or that we were not made aware of initially. I find myself saying, I'm surprised we're just learning this at this point, but at least we've discovered it, and at least they're making an effort to train us on it, and I think we'll get there. So, I also agree that we have no other option other than to get there. We have no option. We have to meet meaningful use in order to get the federal and state reimbursement to cover this large bill.
It's a $700,000 project. Well, maybe I could jump in here then with the timing. I mean, a month ago, I was about ready to pull out the few strands of hair I have on my side, but, you know, with NextGen. And for both of us, the timelines that the feds had placed us under, you know, to certify the 2014 meaningful use standards by, you know, we have to have 90 days of data to do that, and it was supposed to be, we thought, you know, until a couple 3 weeks ago, we thought we had to get this up and go live, and we had to demonstrate the meaningful use in April, May, and June of this year. And I just didn't see any way in God's green earth that NextGen was not ready with their product. You know, I was nervous about us being ready, you know, as Deb and Kirsten have said, just, you know, we're gonna lose. Cliff and I kind of both had decided we were gonna lose this $700,000 and we're never gonna get it. But the feds came through, I guess, and thank God they changed the timeline and gave us another 3 months, okay, to certify. So now we do not have to certify until July, August, and September. So we do have a little more room, you know, to do that.
Is that gonna be enough?
Deb probably didn't want me to say this, but, you know,
Keep it
we
in
wanted
the
to
back
keep.
pocket.
We wanted to keep the pressure on the clinical people to continue to work on this system and make sure that we deliver this thing. So, but that is, it really was a relief to me, but.
Is it enough?
Did I, and I can't remember if I sent the board the little article from the
Sulphur
Springs newspaper.
I got
Okay,
it
so,
sitting right on top at the moment.
I pulled a bunch more
I'll
up too
send it.
after seeing that one.
Well, I'll talk to you about some of it in executive session, but I did have a discussion with the attorneys, and I guess I have to be a little bit careful here, but let's put it this way. Well, and this is what the attorneys told us. We are in a very weak position with that contract because of the lack of due diligence and the lack of legal review. If something goes wrong, we don't have much recourse. So, kind of like Kirsten just said, we don't have any choice, neither from the legal side nor from the meaningful use certification side. So, NextGen and Mineral Community Hospital are in this boat together, and we've got to get this thing, you know, done and certified so that we can qualify for the meaningful use. And we will be working very hard, the whole staff will, and Deb's emailing me at midnight and 1 in the morning about NextGen issues, and, you know, among all the other issues with the clinical staff in terms of scheduling with docs and PAs and everything else, the clinical staff is responding, and we are working very hard from our side. And, you know, I would sum it up that way. We just need to, you know, continue down the path and do the very best we can. I really did feel much better though about the timing. You know, it was just putting a lot of pressure on all of us, you know, to have to certify that thing, you know, by April. Starting April 1, because we have to have 90 days of live data to, you know, to certify meaningful use.
So here's my question. Say this is enough time, we get it done, we get meaningful use. What happens then? The headache doesn't go away. What happens then? Because don't you have to continually upgrade it and learn the new systems? And
Like the VP at the
recertify?
Billings Clinic said to me one time, you know, I asked him, you know, when does the money stop flowing, you know, to the electronic health record
Right.
contractor? And it never ends. I mean,
That's what I'm.
$5,000, $6,000, $8,000, $10,000 a month, you know, for, you know, support from IT, for support from software upgrades. It is a very
Right.
expensive process.
Right, so that's not really something we have a choice on, but it would I just wanna know what we're gonna ultimately what we need to be looking
Right.
forward to, or not looking forward to, whatever.
You know, Cliff,
I mean,
you know, we've been making some payments, you know, to them.
Yeah, we pay about 10,000 a quarter for hosting the system and 5,000 a month for support.
and we're hosting our own system?
No.
Who's hosting?
They're hosting it.
They are hosting it.
Yeah, next gen.
Well, I think there are pieces.
Satisfy-
We get our CMC IT support though, at the Community
Yeah.
Medical Center.
Right.
If you satisfy meaningful use, does that mean that the system is operating properly?
We waived all rights to sue.
No, it doesn't mean that the system is operating properly. It just means that you're meeting the established quality indicators that the federal government has said that you have to meet.
Right.
And those change every
Mhm.
year. They add
Moving-
new-
It's a moving target.
It's a moving target, so, you know, as you get these completed, then they'll add more on and
So-
it'll be more difficult and they'll be different.
We could give you an
Is that
example.
Next Gen's responsibility then to make sure that they are up to date on making sure that you're able to meet those
As being a
requirements?
company that's a certified EHR company, that is their responsibility.
Because I was reading how there were so many, there was a ton that were certified for 2011, but there was only a very small number that actually certified for the next step up.
Or
And that's
lot
gonna
of
be
them are in process.
that's gonna be a continual thing that happens
Yeah, they keep
periodically.
raising the bar, you know, on the standards. You have to do more and more with the
So what
system.
happens to all those people who are on those programs that are with programs that aren't meeting the next standard?
They don't get paid.
Right.
They lose money.
They don't get the meaningful use money from the feds.
Okay.
Okay, let's say we satisfy meaningful use, we get paid. Does that still satisfy your quality assurance program policies?
No, no.
Is there any relationship between them?
They, some, but not much. I don't know, if I were looking at an electronic health record, trying to determine whether or not it was improving patient care, I wouldn't be looking at the types of things the federal government is looking at.
Well, there are some standards in there that,
I was wondering.
in terms
I
of
mean,
patient care.
reporting ethnicity of a patient is a meaningful use, that doesn't get you anywhere in equality.
That gives them a statistic that they
It
can
gives
use.
Yeah,
them a- you know,
exactly.
Doesn't help us.
Right.
You know,
So the feds are doing it for the feds, not for the user.
so some of it is data
Some of it.
collection type stuff that they wanna collect. Other stuff, like, you know, meeting some of the documentation requirements, maybe, but they're sort of, the 2014 big one is having a web portal for patients to go in and be able to look at their own record and do some of that stuff online. That's a huge requirement, and there's only a couple EHRs that I think
Yeah.
can even do it at this point. and so-
Yeah, really.
Wow, that's a big undertaking.
Helen is one of them. I use their patient portal all the time.
Well,
There are some things, though, in the electronic health record that do improve patient safety. You know, one example of that is physician order entry, which is done electronically. And you have, in terms of pharmacy interactions and stuff, you know, you don't have to rely on illegible physician handwriting, which was causing, 100,000 deaths a year or something, you know, in terms of,
Lots of ER visits, hospitalization.
Yeah, yeah, I mean, there's a lot of things in the electronic record that are very beneficial because it gives you better information to manage patient care and more immediate information, but it doesn't necessarily translate immediately. It's expensive, it's a lot of work, it's a lot of stuff that goes on, you know, to make it happen. So there are some benefits, but there's
Right.
also some trade-offs and costs too, in terms of time and effort, efficiency.
Okay.
Well, we're rolling down the path. I guess we don't have any choice at this point.
Yeah. Is there anything else for our next gen update? Let's move on to our dashboard. We kind of did that. DNS report.
Kirsten, you have any comments there?
No,
Yeah.
Missy, I thought we agreed 2 meetings ago that there wouldn't be a DNS report unless the board had specific information they wanted to learn from the.
Oh,
Okay.
well, this
So
is
you
the
could really
hospital.
just.
This is the hospital.
Tell you.
Okay, well, let's move on to our foundation board meeting.
Maybe the
Our
only thing
foundation
of
meeting.
interest there, I did meet with the foundation board. Deb was busy, I think, with next gen stuff, the day of the foundation meeting. She has been going to that with me, but we did request a coag machine, which was listed, you know, we kind of talked about that a little bit in the finance committee, but Tom Olding really needs, the old one crapped out, and he's testing out a new one in the lab. It's about 5,800, 5,600 or 5,800. And they were open to us asking for that funding from the foundation, so that was good news from them. Other than that, there
The
was a
other big
letter.
thing, Larry, is that that letter.
That letter,
To
right.
contributors to the capital campaign.
Yeah,
Giving-
do you want to
giving
talk
them
about
the
that?
opportunity, I just happened to be present for this part of the meeting. They're
Right.
sending out, they drafted a letter that they're going to send out to people offering to refund those contributions that were designated to be spent on building a new hospital.
Right.
And then also recommending that if they did not want to receive that money back, they could continue the donation and in support of other areas.
Right.
Okay.
You know, some people have taken that off on their taxes. If it's a larger donation, they may have taken it off on their
Right.
taxes, and it has some complications there if the money is given back, and some people did not want it back. And so they've talked to some people about that, and, you know, one solution is to just let it remain and designate it for things like the coag machine, I guess, or other things that the healthcare system might want, so. Mitzi, you sent the letter out. didn't
I'm
you?
working on it.
Oh, okay, it's still not out, but.
It's a big project.
Sure, okay.
Okay. Health center.
Okay.
Report.
As I mentioned earlier, the health center meeting for the month has not yet occurred, so I'll be a little bit shorter than usual in information, but we've had several committee meetings. We're continuing to work on getting formal policies in place in areas where we're required to have policies for the HRSA grant and didn't have them, and specifically focusing on some policies related to what we're anticipating in terms of new patients coming in as a result of the change with Dr. Smith and Plains. Continuing to work on areas where we can reduce cost. And that looks like it's going pretty nicely. Was mentioned earlier in the meeting, we seem to be on track to break even as far as cash flow is concerned for this month. We're looking, just as the board here is setting up permanent CEO search, or getting started on that process. We're looking at doing something with that as well. And what we're looking at is a little different, perhaps a strategic alliance. We've been talking to Partners Home Health in Missoula, and there are a couple different approaches we can go with that. And one is to simply contract for management services with them. Another is to essentially become a part of that organization. I think the board's made it very clear they're only willing to consider that if it can be done in such a way that Mineral County doesn't end up losing services in that process. But kind of what we're looking at are two things. First of all, the cost of having a CEO for the size of our health center is pretty high and burdensome for us. So if we can find another way to do those services at a lower cost, that's a positive thing. The second thing to look at is the HRSA grant, which brings a lot of money into this clinic. It's what allows us to offer the sliding scale. requires that we handle a certain number of patients. I don't remember the number off the top of my head. It was a number that was put in the grant by those who wrote the grant. And it, quite frankly, is a totally unrealistic number given the size of the population of Mineral County. By aligning with somebody like Partners from Missoula, those numbers can get all lumped together, and we can probably meet the number of patients seen because we're using their numbers as well as ours to meet them. So this may be perhaps the only way we can save the HRSA grant. And that's over $700,000 of money in order to make it possible for us to offer those sliding scale figures. We certainly haven't committed to a thing at this stage of the game, nor has anybody on the other side. But we're looking hard at that. The CEO from Partners has been up here to several of our committee meetings. I know she came over with Cindy and met with Larry not too long ago. So that's kind of what we're looking at this stage of the game. No final solutions, and there'll be a lot more talked about at our meeting next week. But that's basically what I know of and can tell you at this stage of the game.
So is there, my only, I guess my question is there, when you're considering that, keeping the business here in Mineral County as opposed to them referring everyone out to Missoula?
That's essential to us,
Yeah.
yeah. That's essential. It's gotta,
We were talking about ancillary services and whatnot, I mean.
Right, yeah, it's
Their
essential.
primary feed is the clinic here.
Absolutely, it's essential. Yeah, I mean, again, I think everybody on the board is focused on making sure we do what's right for Mineral County. And what is right for Mineral County is making sure this hospital does okay as well. I mean, absolutely essential that this hospital be here and there be an emergency room here in Mineral County. And that's why I say no commitments have been made, these positions have been made clear. But anything we do is going to be in writing. Everybody's going to look at it, and part of what we're going to look at is making absolutely sure that we can continue to make the services and keep all of the services for health that we need in Mineral County. And one of those services is without a doubt the hospital.
Give you one example, the partnership has a mobile dental clinic in Missoula.
Right,
And they're willing to bring it out for us, so we wouldn't have that investment.
right,
But we have to develop some sort of
an
a
agreement.
MOU or agreement
Yeah.
to allow that to happen.
Yeah, and we have to, under our HRSA grant, provide the dental services.
right.
So this lets us do that, bring it here, but all the way along the line, believe me, we're all gonna be focused on making sure we don't do anything that hurts healthcare elsewhere in Mineral County, and that's here.
There's one more thing on dental. We're still gonna be using the local dentist.
Yes, yeah.
Don't take that the wrong way.
Yeah, yep. Yeah, I mean, I think kind of some of the talk about that service, and we've communicated with the local dentist, let me see if I get it right. I think it's his wife is a physician who's not yet relocated to the United States from Guam, I guess military, and we're talking with, possibly working with her as well. It's actually, as best I can tell, the local dentist is presently overwhelmed with patients. He'd opened a clinic in Plains as well, and the last I understood, he was looking at bringing somebody else in to run Plains so he could be here full-time because he's got so many patients, which is great.
We've talked to the physician also, female physician,
Yep.
and his wife, and she's not particularly interested in hospital. ER is not her strength. She indicated she would do that if she had to, but I don't think at this point we have a need. Anyway, we're pretty well covered. Although we-
Especially, I think, it's family medicine.
Yeah,
Well, right, but that's the same with Dr. Pafford. I mean,
Right.
he covers both sides though, and is
Right.
comfortable doing that, but apparently, this lady's name is Dr. Parker, right? Parker,
Mhm.
right. And she she's not real strong with ER skills, and we probably would not plug her into the ER schedule, but Cindy, I think, could use her on the other side for fill-in and, you know, to develop a practice. It would be great to have, and she really likes peds, you know, it'd be great to have a peds over there, you know, and, you know, someone who likes peds. Pediatric. Pediatric, you know, treats kids.
Tell Cindy to get a receptionist that knows how to smile. I went in there yesterday for a pre-surgery.
Okay.
physical,
I've
it's-
had a conversation about the receptionist within the last week with Cindy as well, so.
She's got the personality of Dr. Lovell.
Yeah, well, and I'll live a little bit with her not smiling if she does callbacks and delivers messages, so I'm working on that
Jim.
first.
One other thing I might mention, John, is Cindy has submitted an officially grant for another
Oh, yeah.
round of funding from HRS. So
Yes, yeah,
that-
thank you.
That's finished and well done and even received, so we got the deadline over with and all the data in, so felt good about that.
Yeah,
that was
she
a big
kind of got
hurdle.
blindsided on that a little bit. All the information she had was that she had a lot more time to get it in than she
Right.
had, and all of a sudden, whoops. So
But it was-
she was
she
doing
did.
a few midnighters there,
Okay.
I think, but yeah, she got it
Sure
done.
was.
Okay, anything else from the health center? Do we have?
John, was there any discussion about the quality program in the health center?
There was a little bit of discussion, but again, we haven't had our regular meeting yet. But we do have a quality committee that's working forward. We kind of got sidetracked a little bit on some of the policy issues because of what's going on, but yes, we are working on the quality program.
They
We-
have some pretty stringent quality requirements on the
Yes.
CHC side. I mean, it's,
Yeah.
physicians and mid-levels will do this, and you must do this, and this, or your contract is terminated, and mainly for their liability through the Federal Tort
Federal Tort Claims Act, yeah. Yeah, and
It's
that's.
pretty strict that they must do these certain protocols in terms of
Yeah.
quality.
Yeah, and that's a pretty big deal, too. The